Thank you, Professor Weil, and thank you, the committee, for inviting me today. I'm really in awe of the wonderful committee, the members, and the wonderful lectures, and really quite humbled. And I want to thank Professor Nofel, particularly, and Dr. Weil for their help with my recently attained PhD as well. So thank you very much. Today I'm talking about precision, prediction, and personalization in medicine. And the definitions are simple. From precision perspective, it's about the right diagnosis, the right therapy, the right patient at the right time. Prediction is about anticipating the disease, ideally before symptoms or deterioration. Personalization is about tailoring the prevention, diagnosis, and treatment, and doing it according to the individual's unique genetic, clinical, and lifestyle profiles. So, firstly, precision. How can we achieve it? I'm going to just give some examples of the three Ps, and there's so many more examples available in this current era and the new era of medicine. So, from a genomic point of view, you can use genomic transcriptomics, single-cell sequencing, and other aspects of omics. We can use advanced imaging, we can use biomarkers and molecular diagnostics. And as Professor Nofel mentioned in his lecture, we can also, an example would be the utilization of computer vision in a precision type of manner. And I would like to basically just quickly skim over Dr. Professor Nofel already mentioned what is computer vision and which way things are heading. But importantly, the deep neural networks and the ability to be able to handle data using GPUs and doing all the things, and also now cloud computing is allowing us to take the utilization of computer vision to the next level for our imaging and other aspects of the application. And particularly useful in the computer vision side of things is something called convolutional neural networks. Basically, you have an input layer, hidden layers, and an output layer. And what they do, as Professor Nofel has mentioned, is try to make sense of the pixels and lead to the endpoint of classification. To give you an example, I'd like to quote the work of Dominguez and Rodriguez in 2023, who looked at pediatric chest X-rays and tried to see if we can get patterns and make predictions from that. So basically, a man versus machine scenario. In that scenario, you have an option where doctors and machines agree, which is called a true positive. Where they disagree, it's a false positive. And in the true positives, of course, there was the pneumonia was present. And then the true negatives, doctors and machines agree that it's a negative scenario, or there's a disagreement and actually it was negative, but falsely the machine thought it was positive. So, if we look at the data and the way it's come out, you can see actually the data is able to be separated between pneumonia and non-pneumonia. You can see at the top, the pink, which is the pneumonia side, and below is the non-pneumonia side. But it's not able to differentiate between the true positives and false positives, and the true negatives and false negatives. The scenario, basically, the take-home message here on this slide is that AI is strong when there is pneumonia. But errors occur in the FP and FN. FP, false positive, usually when there's maybe atelectasis or other non-infective phenomena. And the false negatives when there's certain type of problems, such as a viral infection. If we look at the same data and we look at it according to the etiology, you can see here TP and TN, we're happy with those, but how can we minimize the false positives and the false negatives? The issue is when their etiology is either viral or atypical bacterial. And so that's the key takeaway. But we can now utilize these phenomena of computer vision in the workplace to improve the agreeability between clinicians. Computer vision can also be applied in other ways. Here is the same woman, 29 years old, with Hodgkin's lymphoma. You can see how the two sides light up almost equally, but on the right there's less use of the isotope in the PET scan. So there's other benefits of using computer vision in these kind of scenarios. From a prediction point of view, so moving on to prediction, how can we use machine learning from a prediction perspective? Or how, as prediction improved in this current era of medicine? Well, we can use machine learning for looking at risk scorings. It's also possible to do predictive analytics now on electronic health systems. We also have variables and real-time monitoring. And also we can apply it to different scenarios, such as predicting cardiac arrest in the ICU, or predicting outcomes in patients with sepsis. On that matter, in my work, which was started in 2009, we looked at patients with sepsis, and we particularly focused on transcriptomics. So this is a microarray gene chip in silico work. So basically what you do, you look at the messenger RNA, and we did it across time points. You bring the mRNA out, you copy it against cDNA, and you basically hybridize it on the chip, and the chip is then used to look at the level of immunofluorescence. The problem with sepsis, you can see this in this sepsis diagnostics, is that there's a lot of data, and but problem is there's a lot of heterogeneity. Sepsis is a heterogeneous condition. Treatment, the pathogens, the port of entry, the variation of treatments, the host pathogen interactions, all these things cause problems, and there's a lot of noise. We can use two basic ways of analyzing and looking at the data. Use a statistical methodology or machine learning. What's the difference? Statistics, you do need an appreciation of the framework. You do need to have a really good idea that, this is how things are defined, and this is how things progress. But unfortunately, sepsis definitions have undergone multiple iterations over the decades because it is such a difficult condition to pinpoint. Machine learning, on the other hand, says I don't need to know about all these patterns, but the frameworks, but I just need to work out the patterns, and from the patterns, maybe there will be something useful. So, as I mentioned, we looked at the gene expression over time. You can see the arrow there at the bottom, and basically, what we did with that was we expressed the mRNA in different time points to try to track the condition. Problem with sepsis is, as you can see, patients vary. They can vary in size and age, and also they vary in when they come to hospital and how they manifest with infection, and then how they progress. This is a child I picked up from the emergency room in the morning, and with a few spots on his feet. And by the evening, you can see now, you may be able to discern that his legs are black and blue. He's intubated, he's ventilated, he's got multiple drugs there on their side to keep him alive. So somehow, if we could predict even before this scenario, that would be ideal. We use things like CRP and procalcitonin, but they're not very specific and precise biomarkers. In my work in 2009, and we published in 2013, we said, hey, it's actually very, very complicated. Statistical approaches showed that basically it's not possible to work out what's happening at the genomic level. Ideally, we need a system whereby everything can be standardized and patients come at certain time points and you can then follow them across the time points. Unfortunately, life is not like that. So we took the data and we looked at the data. And the problem with the data is that actually, and this happens in sepsis data sets, you have majority data, which is normally patients with outcome, fortunately. Outcome is survival. But there's always a minority group where there is an endpoint of non-survival, okay? So there's imbalance. And this is what happens a lot in the sepsis studies. But the advantage of machine learning approach is that you can actually synthetically generate the minority class, which is the endpoint of non-survival. You can actually, increase that synthetically, which is amazing. So with our data set, we had 29 samples over various time points in 5 patients and 1 non-survivor. We were able to reduce the data using something called primary component analysis. And then we use 70% of the data to train the models, the machine learning models, and we left the 30% to test how good those models performed. And in doing this, you can see here we have two areas. We have imbalanced data set, which is the original data set. And then we have something called balancing, where the weights of the neural networks are balanced going backwards. The artificial neural network at the bottom did very well. This is a feed-forward neural network. That was very well. In fact, too well. And so well that we have something called overfitting, where you give it data and it'll just quantify things according to that data set. So this is something that we need to look forward in our work. But balancing allowed us in 3 or 4 different scenarios to increase the prediction. So the prediction scores of 1 is the ideal 100% scenario, can 100% predict which way things are going. But you can see here that the test scores actually, with 93%, 93% prediction in some of the models. So this is the first time we used temporal transcriptomic messenger RNA data to predict the endpoint in sepsis. Now moving on to personalization. Personalization, as I mentioned, is about tailoring prevention, diagnosis and treatment to individuals' unique genetic, clinical and lifestyle profile. And there's many different ways of doing this. Something called digital twins, where you will try to model the patient from a digital perspective. You've already heard about the bioprinting. That's also perhaps a way also physically of trying to get organs that are digital. For example, the work of Professor Shabir tried to build a brain that would be similar to the patient's brain, so you would know how the seizure medication will be impacted. Cancer vaccines we've also discussed. So now tailoring. I decided to just move away slightly from the AI side of things, but you'll see how customization can happen from an AI perspective, but to come to the utilization of bacteriophages, which are viruses that attack bacteria. It's possible to program these, to select these naturally, or use a cocktail or genetic engineering process to attack specific bacteria. And in the era, antibiotics can kill bad and good bacteria, but phages are very, very much more specific. You can have a stage approach where the phages will go, you can have a stage approach where the phages, for example, come in and go for long chains, or they can come in and go for short chains. So you can give them at different levels. Or, as in the third thing, you can have a cocktail of phages that will come and attack. And then the third is the utilization of phages and antibiotics. Here is a really illustrative graph with using statistics. Statistics still has a role, though we're all talking about machine learning. You can see here the greens are on top. This is all Staph aureus. You can try different antibiotics and phage combinations, and it drops in the 3D epithelial model. It drops things down. You can see it drop. But the most impressive drop down to the baseline, it shows the efficacy in the gram-negatives, Pseudomonas aeruginosa group. You can see how that's dropped. And particularly the combination of an antibiotic and a phage has that impact. So very, very, very interesting. So as I mentioned, Staph aureus, gram-positive, it's a issue because it's a resistance mechanisms, it's a biofilm, and it's a problematic. But for the gram-negative side of things, amazing. And surely there are some great case studies in the literature, utilization, life-saving, when they're able to cater bacteriophages, as in the case of Acinetobacter sepsis, Klebsiella bone infection, a patient who'd been treated for 700 days and almost failed antibiotics. Patient with cystic fibrosis with a Mycobacterium abscessus lung infection. Prospective CF trial where they've actually shown sputum burden to go down and increase in lung function. So phage therapy is moving from the last chance to a structured, evidence-based medical approach. Given all these technologies still the complexity of clinical medicine, and particularly my work in terms of sepsis, we're looking to integrate a lot of different variables that will come together and work out an evidence-based approach. So really interested to see how that moves forward. How the future of medicine will look, we've seen the trajectory from the catheterizations, mechanical ventilators, and the digital twins to potential utilization of robots. If you want to read more about our work in machine learning and sepsis, we presented our work in Boston. And now, with only a few seconds to go, I'd like to basically say that, the new era is about augmenting human intelligence, making medicine safer, and more human-centered. Thank you very much.